Okay, good afternoon, everyone. Thank you for being here on a Saturday afternoon to attend our webinar. And of course, we are doing this in conjunction with the World Mental Health Day and also World Heart Day, which was recent, about maybe 2 to 3 weeks ago. So I have here an esteemed guest, Professor Dr. Hatim, who actually is not just a clinical psychiatrist, but has a PhD in
Psychopharmacology.
Pharmacology. Yes, amazing. It's a receive. It's not enough that you did postgraduate in psychiatry. You did a PhD on top of that. Okay, and I have Dr. Barclays, who is a physician and also a cardiologist who is currently in IJN. But I heard that following this IJN stint, you're going to teach in a university, is it? Barclays? What happened to Barclays?
I'm in UIA, from UIA, IUM.
Oh, I see. So you're going back there to lecture?
Yeah.
Oh, that's great. So all in the academia.
Yeah.
Okay.
So my virtual background is my hospital in Kuantan.
Oh, I see. So when I drop by Kuantan, I will go and visit you.
No problem. Just
when are you? When are you?
Early next year. I will be back in Kuantan early next year.
I see. And you will set up a cardiology unit in there?
Yes, yeah. Actually, now, if you know Datuk Hadi joined us as a contract. He was the head of department in Hospital Kuantan. Then he joined us after he retired.
I see. So now he's going to teach also.
Yeah.
Okay, good. Okay, so without further ado, we just invite the Prof first, and then you will follow, yeah? If you have any questions, anyone, just put in the chat group or raise your hand, and then we will take questions later. Okay, so
Okay, can you see my slides?
Yes, we can see your slide. Maybe you put on, yes, that's right.
Perfect. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good evening. Thank you very much, Dr. Betty, for the kind introduction, and thank you for having me here and giving me the opportunity to speak. It's a great pleasure to be meeting all of you. Even though it's online, I hope one day you can meet face to face,
yes,
especially
right.
after the MCO. It's more. Not to say over, but
yes.
at least you can have face-to-face in the future. Okay, I'll be talking about mental health and cardiovascular disease, but I mainly will focus on depression because this is the most common psychiatric condition. And also I'll speak a little bit on anxiety disorder, especially the panic disorder, which is, I think, quite relevant to cardiovascular disease. Okay. Mental illness is still highly stigmatized, unfortunately, and there's a lot of misconception about mental illness. Even now in the era of IT, a lot of people already have Facebook, all the internet, all the everything on WhatsApp and everything, but still people believe in all this charm, chakra, demons and bad spirits, associated them with mental illness. So even though in KL itself, before they come to psychiatrists, if patients have symptoms of emotional disorder or symptoms of mental illness, they won't come to see psychiatrists first. They will probably visit the ustad first, the traditional healers, and they always believe that this is due to bad spirits, demons, or especially for the Malays, they believe that, oh, the illness is because you don't pray enough, you tak baca Quran, for example, you tak bersyukur, you develop mental illness because you are weak, you are lazy. So these are a lot of misconceptions about mental illness. And another important things that people always thought that if you have mental illness, you will recover by itself without treatment. So unlike other illness, if you have myocardial infarction, nobody will have a negative comment. Say, oh, you have MI because you don't pray properly. You have MI because you are not grateful to God. But unfortunately, if patients have mental illness, these are some of the comments that people have. And a lot of people don't know, but actually there's a lot of famous and rich people, famous and very productive people have mental illness, especially depression. I'm sure some of you will know The Rock, Dwayne Johnson, very famous actor, and he openly say he have depression. So he's probably one of the highest paid actor in Hollywood now. Robin Williams, funny guy, always act in a funny movie, but he finally committed suicide due to depression. J.K. Rowling, she's a very famous author, and I think he's a billionaire because of her book and her movies. But she also have major depression, and she admitted to have major depression before. Lady Gaga, again a famous singer, also one of her albums is based on her problem with major depression. For those who are in sports, probably you know Michael Phelps, who won 21 Olympic gold medals. Malaysia never won even one gold medal. He alone won 21 Olympic gold medal. In between the Olympics, he had depression, and still after that, still able to win gold medal in swimming. Buzz Aldrin, the second person who walked in the moon. After he come back from the moon, he developed depression. And Abraham Lincoln, probably the best US president, also suffers from depression before, but still able to run USA. So actually a lot of famous people have depression, but the good news is that patient can get cured can get well and able to function even with after proper treatment with depression. So depression is actually a chronic medical illness, just another brain disorder, just like probably stroke. But unlike stroke, it's not the disorder of lesions, more of a disorder of circuit. So if you do a CT scan or MRI, you can't see any changes in the brain because it's not a lesion, but more at the cellular level. So if it's not treated properly, it can lead to morbidity and mortality. However, the good news is that with proper treatment, full recovery is possible. Unfortunately, the majority of the patients are not detected. In this study in the US, even in the developed country in the US, 50% of patients with depression are not recognized by the doctors. And only about a quarter of the patients receive adequate treatment. So it's largely untreated and undetected, even in the developed countries. And in Malaysia, so it's still the same story. So let's look at some of the data in Malaysia. This is before COVID-19 pandemic. So this is 2018 data. So the total population in Malaysia at that time is estimated around 32 million, with our healthcare spend about 1% of the GDP, which is 4.1% of the GDP. So the psychiatrists at that time is about 400, slightly more than 400. So the population per psychiatrist is about 75,000 person per psychiatrist. So the prevalence of MDD is estimated around 3.8%. So about 1.1 million people have major depressive disorder, estimated. And the suicide rate is about 6.2 per 100,000 population. But now with the ongoing pandemic, there's escalating cases of depression and suicide in Malaysia. This is a study conducted by one of my colleagues in UMMC. So from their finding, they found that within the first part of the pandemic in May last year, they surveyed about more than 500 respondents. Almost 1/3 of the individuals have either moderate or mild to severe depression nationwide due to this current pandemic. And in addition to that, Malaysian authorities reported almost 500 suicide cases in the first 5 months of this year. So on average, 100 person committed suicide and died because of suicide. That is the reported case, and that much more unreported case is happening. Yeah. So the pandemic really fuels the situation. So COVID-19 is a traumatic stressor because we are living in a global mass trauma event. So the same event is happening everywhere. So probably this is the worst since World War II, and probably the worst in terms of in our lifetime. And it's affecting all areas of our life, social, health, financial, creating a lot of distress, and obviously exacerbate mental health issues and causing a lot of mental illness. So the main reason is the obvious problem is the bereavement associated with this pandemic. Even in Malaysia itself, more than 25,000 people already died due to COVID-19. So, and especially for the loved ones, there's a rapid deterioration in patient with COVID-19 and sudden death. So the patient will die within few days. So that really make emotional preparation hard for the relatives. And even for the healthcare workers, especially those who have to care for critically ill patients, face a lot of traumatic effect due to this pandemic. Yeah? So affecting millions of people, and I mentioned earlier, it causes a lot of mental health issues. And we are seeing more and more patients with depression, with anxiety, probably double or triple than pre-pandemic era. So what is a depressive disorder? So it's a medical illness that affect the patients, mainly their emotions, mood, and also their thought, their thinking. So it is not a normal sadness. So it's not the same as having normal sadness. Everybody will feel sad once in a while in their life. If you never feel sad, then definitely you're abnormal too. So sadness is normal, but depression is an illness. So how do you compare normal sadness and major depressive disorder? So one is physiology, one is pathology. Just like in cardiology, in physiology, if you exercise, you have increase in your heartbeat. So then it's normal. That is physiology. But suddenly you have abnormal cardiac rhythm. Then that's an illness. That's a pathology. So similarly, normal sadness is physiology. Everyone experienced by everyone. Normal sadness. You feel sad, that's normal. But it occurs only at a certain period of life, a certain time, lasts for a few days. But normally it won't affect your function. So that's normal sadness. But major depression is an illness, which is your mood, your low mood become persistent. So it lasts for weeks, months, or years. And it will impair your daily function. And it's also associated with other symptoms as well. So it's not just the low mood or feeling sad or depressed, it's associated with other symptoms. So what are the main symptoms of major depressive disorder? So the main symptoms, of course, depressed mood, feeling low every day, almost the whole day for at least 2 weeks. So you feel low, for feeling depressed every day, almost the whole day for at least 2 weeks, you have the main symptoms of major depression. The second important symptoms is anhedonia. You have inability to enjoy things you used to enjoy. Let's say you enjoy eating roti canai or nasi lemak. So that doesn't give you pleasure anymore. Or and after work, busy day working, you go back home, you see your family, your spouse, your children, you enjoy seeing them, but you lost that enjoyment. Though probably you have anhedonia, or chatting with friends cause enjoyment. If you lost that, then probably you have anhedonia. So you easily get bored over things. So you also associated with feeling tired, no energy. Some patients will have painful physical symptoms, chronic pain, which is unexplained by medical examination, so chronic headache, chronic backache, back pain. But when we examine, nothing is there, and probably that's also symptoms of depression. Insomnia, that means difficulty to fall asleep or maintain the sleep or the poor quality of sleep, or hypersomnia, you sleep more than usual. That's also a very important symptoms of depression. It also affects your appetite. You can probably eat less, or you eat more than usual, not because your appetite is increased, because every time you're stressed, you be eating and eating and eating. So the results are the loss of weight or increase in weight. It will affect your concentration. You have difficulty in having conversation. You have difficulty in reading. You have difficulty in watching television. You can't follow the story. So poor concentration. This will affect your work. It affect your studies. If you are a student, they have difficulty in studying. Psychomotor retardation, slow in all the movements and the thinking process. So as it becomes worse, the patient will have feeling of worthless and hopeless, and uncontrolled guilt feelings. And as this going from bad to worse, patients start to have suicidal ideation, and they think that life is not worth living and better off dead. So, okay, these are the 9 symptoms of depression. And if you have more or 5 or more of this over a 2 weeks period, so based on DSM, Diagnostic Statistical Manual, DSM-5 or ICD-10, you are having what we call major depressive disorder. So depression is a very disabling medical condition. So this is based on a study conducted many years ago, more than 20 years ago, published in JAMA among 11,000 patients. So they look at degree of impairment in functioning and well-being, and compared to other physical illness like hypertension, diabetes, arthritis, lung disease. So the other more disabling condition is a heart disease. So depression is worse than other physical disease like diabetes, hypertension, and arthritis. So it's very disabling medical condition, cause a lot of physical disability, social and functioning disability. So because of this functional disability, it's very costly, costs more than 31 billion US dollar a year. This is a US data. It's the second leading cause of disability after cardiovascular disease. And majority of the patients who have depression will have severe impairment in your quality of life. And what is worrying is that the suicide risk is very high, 25 times greater than general population. And WHO has estimated around 800,000 people. This is before COVID-19 era. So about 800,000 people died due to suicide every year. So about 60% of them suffers from major depressive disorder. It means they also estimate that from each adult who died by suicide, there are probably 20 others attempting suicide. So if you use the data in Malaysia based on the police data that about 100 patients died due to suicide every month this year. So it's probably every month there'll be more than 2,000 patients attempting suicide in Malaysia itself. There are probably more than that. So what are the risk factors for getting major depressive disorder? If you are female, you are twice more likely to be depressed than male. The peak age between 20 to 40 years old. So it's the most productive age of life. If you have a family history, the risk goes up to 3 times higher. If you are divorced or separated, increase the risk. Postpartum, especially the first 6 months after delivery. You have negative life events, especially like the pandemic now. And you have suffered serious medical illness like cardiovascular disease. After a myocardial infarction, it increases the risk of having depression, or you have heart failure, for example. It also increases the risk of becoming depressed. So there's brain changes occurs in depression. It's not just a functional disorder. It can cause brain atrophy, especially in the hippocampus region. Okay, so there's a model for this pathogenesis. So when there's a lot of stress, there'll be increase in the glucocorticoids, all the stress hormones. And prolonged increase in all the stress hormones is not good for the brain, especially for the protein brain-derived neurotropic factor. This is important protein that that support the survival of this neurons. So if you don't have enough of this protein, the neurons will undergo atrophy or apoptosis, death of the brain cell. But with treatment, for example, pharmacotherapy, psychotherapy, or even exercise, this can increase the level of brain-derived neurotropic factor, and thus increasing the survival of the neurons again. So it's just like when there's not enough sunlight, there's a lot of rain, and it erodes the soil. So your tree can die. Yes, this is analogy. So you have a lot of good sunlight. There's no erosion of the soil. Then your green trees can grow properly. So what's the relationship between depression and cardiovascular disease or other medical disease? So comorbidity of depression and medical illness is very common. So the rate varies from 10 to 40%, depending on the severity of the illness. So many medical illness, including cardiovascular disease, increase the risk of developing depression. And depression may negatively influence the outcome of your cardiovascular disease. So I just give example of few studies related to cardiovascular disease. Example, this paper again published in JAMA in 1995 by Professor Fraser Smith, where patients who were depressed at 1 week after their myocardial infarction were 4 times more likely to die in the next 6 months than those who are not depressed. Yeah? So if your patient after MI, they develop depression, the risk of dying is 4 times more than those who are not depressed. So it's very important to detect. After MI, if they are depressed, better treat them properly. Otherwise, the mortality rate increased by 4 times based on this study published in JAMA. And a review of 22 studies found that 2 years after an myocardial infarction, depressed patient had 2 to 2.5 times higher risk of dying of a cardiac event than non-depressed patient. And depression also predicts higher morbidity and mortality rates in patients undergoing coronary artery bypass, congestive cardiac failure, and heart transplant recipient. So there's a lot of problem if you have depression together with cardiovascular disease. So they have complicated presentations, they have poor adjustment to the medical illness, and that definitely there'll be delay in recovery time and increase in mortality. And are depressed patients more likely to be medically ill? So the other way around. If you are depressed, if you have medical illness, the risk of depression increase. But if you are depressed, can you become more likely to be ill? So there's also studies to support that if you are depressed, you can develop other physical illness easily. So in these studies, among the depressed patient, they have higher prevalence of getting heart disease, up to 30%. Yeah. So okay, so next I'll just switch a little bit to another disorder, which is panic disorder. So this is also very common presentation to emergency department, general practitioner, and probably common in referred to cardiology. So this is what we call a panic attack. So is it a panic attack or is it a heart attack? So patient normally presented with extreme fear of having heart attack or stroke. So normally they have palpitations, difficulty breathing, chest pain, they'll be sweating, dizziness, increased blood pressure, just like symptoms of heart attack. But knowing the differences can be very difficult. So this typically affect young patients, and especially female patients. So how do we differentiate? Sometimes it's very difficult to differentiate and cannot differentiate at all. So in terms of pain, both will have pain. So in panic attack, it's more like a stabbing, sharp central pain, whereas heart attack is a squeezing pain. Both have sudden onset, but normally panic attack is associated with extreme stress. Okay, one of the differentiating factors is in panic attack, the pain gets better over time. But for heart attack, normally get worse over time. And in panic attack, symptoms resolve in 20 to 30 minutes, not more than 1 hour. Heart attack lasts the symptoms lasting longer. Both will have symptoms of shortness of breath, sweating, and in panic attack, normally they have tremor. So panic attack will not cause a heart attack. Panic attack, patient will not die from panic attack, but they can die from heart attack. So for the first time, it's better to rule out dangerous conditions like heart attack or stroke. However, if the patient keep on coming to A&E having the similar symptoms, then probably they suffer from panic disorder, and referral to a psychiatrist I think is a good option. Once you have ruled out the heart condition. Okay, so this is, I think, quite common presentation to emergency department. Okay, what are the treatment options, especially for major depressive disorder? So you can normally psychiatrists can use psychotherapy, pharmacotherapy, or electroconvulsive therapy. So I don't think you have time for psychotherapy, and ECT is more for inpatient. But pharmacotherapy, even cardiologists can start, or even general practitioner or other discipline can start pharmacotherapy for depression or even anxiety disorder. So all the antidepressants aim at increasing the level of the noradrenaline, serotonin, or dopamine. So basically, we have a lot of antidepressants in the market. Actually, antidepressants are very easy to use. Very easy to use. I think it's easier to treat the major depression than hypertension or diabetes. Very easy. The medication now are very safe. Safety profile are excellent for especially the newer antidepressants, and you don't need to do any special monitoring. Okay. So there are so many different types of antidepressants now, which are easy to use. Most of the starting dose is the effective dose. There's no complicated titration required. So I mentioned starting dose is the effective dose, and you don't have to monitor anything. As example, any specific investigations. So how do you start the antidepressant? So you must look at the efficacy. So if most of the antidepressants are very effective, if they have prior history of depression and on certain medication, so you just start back the old medication. If this is a first episode, then you can always try any one of the newer antidepressant. So you look at the patient's tolerability as well, and explain to the patient about the anticipated side effects. Okay, especially the SSRI, which is very safe and very few side effects. Mainly is the GI side effects, nausea, probably vomiting. Rarely patient have vomiting, but nausea, some headache, but that is very mild side effects. And you have to look for other general medical conditions. The drug-drug interaction for most antidepressants are very favorable, and majority of the antidepressant now are quite cost-effective, not that expensive, and not very expensive. Okay, so there are many different types of antidepressants. The most common one is the SSRI, selective serotonin reuptake inhibitor, like escitalopram, sertraline. There's also SNRI, serotonin norepinephrine reuptake inhibitor, the NASA, the melatonergic agent, and also the multimodal antidepressants. Okay, I use up my 30 minutes. Okay, so summary. Depression and anxiety are very common medical conditions, and suicide and self-harming behavior are worrying complications. Patient, in fact, died due to suicide. It is a serious illness, but treatable, so it can be easily treated. And with proper and adequate treatment, patient can recover fully from depression and anxiety. Okay. With that, thank you for your attention, and pass back to Dr. Betty. Thank you very much.
Thank you so much. Very, very interesting, very, very simple. Okay, anybody should be able to understand it. And I think that it is very important to stress the fact that it is treatable. Okay, why suffer fear and sadness when it is so treatable? So I cannot understand some patients, of course, if they have cancer, they will treat immediately. If they have hypertension, they are more likely to be treated. But when they have a psychiatric illness, it is very, very difficult for them to convince them, for us, even me, to convince them to see a psychiatrist. But before we take questions, Bakris, maybe you'd like to try to share your slides.
Okay.
And when you have a very, forthcoming, pleasant psychiatrist like Prof, I mean, what is the problem? Okay, Bakris.
Can I start my presentation, Dr.
Yeah,
Betty?
please, go ahead.
Okay, thank you, Dr. Betty. It's a nice talk listening to Prof. Hatim. So my topic today is almost similar like Prof. It's related to cardiovascular and also psychiatric illness. So I would like to discuss more about cardiovascular symptom as a presentation of psychiatric illness. Sorry, my slide is not moving. Okay, so how close myself to be a psychiatric? Actually, when I was during my final day in medical school, my professor in psychiatry, I'm not sure whether Prof. Hatim know him or not, Prof. Fazila, he asked me to come to his room and he asked me, Baklish, would you like to become a psychiatrist? I can arrange a place for you in the university. I was graduated from UNIMAS last time. So I told him, I would think about it, Prof. Then I start my housemanship. Then I realized that psychiatry is a very difficult field for me that I cannot I have a very short span attention, so I cannot really listen to people. So I decided to go to internal medicine and cardiology, because cardiology just need a very short attention span. We just see, am I diagnosed? Then that we
yes,
go
very,
to the
very fast turnover.
then we pass over to the
the next
other
few days you
people.
go out.
Yeah. So actually, there's a bidirectional link between psychiatric illness and heart disease. So I'm glad during preparing this presentation that actually there's a link between psychiatric and there's even a psychocardiology subspecialty in a dream pipeline, because they said this to train and provide expertise needed to detect cardiovascular disease risk in a psychiatric patient. Like Prof mentioned just now, there are a lot of psychiatric patients who also have cardiovascular disease, and there are a lot of cardio patient who has some psychiatric illness. So 40 to 60% patient with cardiovascular disease also have clinical depression, like Prof mentioned just now, and 30 to 50% who have diagnosis of abrasion at a risk of developing cardiovascular disease. So these are the common cardiology symptoms that encountered in our cardiology clinic. Most common symptoms are chest pain, shortness of breath, reduced effort tolerance. Usually these are associated with heart failure and underlying coronary artery disease, leg swelling, and sometimes they are also presented with syncopal attack and also palpitation. Like Prof mentioned just now, palpitation is also a presentation of anxiety disorder. So I would like to share a real story of a schoolmate of mine. This is Dr. H. She's actually a 35 years old lady. She was my schoolmate during secondary school. Currently, she's doing master in ophthalmology. She was initially presented with shortness of breath and chest discomfort for 3 days. Of course, when anyone who presented with chest pain and shortness of breath, the basic investigation was done in emergency department. They did ECG and chest X-ray, and the ECG showed there's a T inversion at V1 to V3, 3, and AVF, which might be a non-specific for a lady at the age of 35. The cardiac enzyme also was not elevated. Then, of course, during this pandemic area, everyone was tested with COVID PCR, and unfortunately, she was positive. So she was treated with SES at the same time, and also with concomitant COVID-19 pneumonia. While during quarantine, she had recurrent chest pain, palpitation. Of course, during the 14 days quarantine in the hospital, multiple investigation was done, because there are so many data saying that patient who diagnosed with COVID-19, they prone to develop pulmonary embolism, DVT, which is, I agree, I encountered a few patients who developed acute coronary syndrome, and also pulmonary embolism, and also deep vein thrombosis when they develop COVID-19. So I agree with the treating doctor. They did all the necessary investigation, and fortunately it was normal. So after she was discharged, she had recurrent episode of palpitation associated with cold peripheries. So she contacted me and asked my opinion, and she self-referred to myself. So palpitation is a feeling of fast heartbeat, fluttering, and pounding heartbeat. Basically, it's just an awareness of own heartbeats. It can the causes of palpitation can due to a benign disease and even a life-threatening presentation of a heart disease. So it's important to rule out a few important diagnoses. So the approach to palpitation, first, of course, we back to our medical school era. We first need to take a good history of the symptom. We ask duration of symptom. We need to ask other associated symptoms like any syncopal attack, any features of reduced effort tolerance, any associated with chest pain. Then we need to ask the patient whether they have any precipitating factor, especially to coffee, alcohol, whether the palpitation also occur during exercise, any associated with emotional stress, any particular drug that can cause the palpitation. And most importantly, we must ask the patient whether they have any history of sudden cardiac death. So on physical examination, we need to rule out any hypertension, because hypertension also can associate with palpitation. We need to take the patient blood pressure, make sure the blood pressure is normal. Then, of course, we need to rule out features of thyroid disease, because this is the most common symptom of palpitation. The thyroid disease has the most common thyroid disease symptom is palpitation. We also need to look features of anemia, because patient who has low hemoglobin can also have palpitation. Then we need to palpate the patient pulse, make sure the pulse is regular and there's no irregular pulse. So after that, we need to proceed with full cardiovascular and respiratory examination, and look hard for any cardiac murmur, any features of heart failure, and any features of chronic lung disease. So these are the few important 12-lead ECG that we need to able to pick up in primary healthcare. So WPW is always associated with supraventricular tachycardia, and it's very easy to diagnose. First, we need to identify delta wave. Delta wave is actually a notch before the beginning of the QRS complex. And the other criteria of WPW is a short PR interval. So the normal PR interval is usually 3 to 5 small boxes, ECG boxes. These 3 small ECG boxes. So in patient with WPW ECG, usually there is a short PR interval. So in patient with WPW syndrome, they tend to develop this paroxysmal ventricular tachycardia. So usually the tachycardia will have a small QRS complex. So the treatment for WPW syndrome is very easy. We love the beta blocker. Usually I will prescribe the patient with bisoprolol or verapamil. Then if the patient still having very frequent palpitation, usually we will send to our electrophysiologist colleague, and they can do ablation for them. Then the success rate for ablation in WPW is very high. Some code is almost 100%, but I would say there are a few number of patients who still develop recurrent. Then the most important diagnosis not to be missed in patient who having palpitation is atrial fibrillation. Usually in the ECG there is no visible P wave. There is a irregular RR interval in the QRS complex. Atrial flutter, we can see the baseline here. There's a flutter wave or sawtooth appearance of the baseline ECG. And sometimes people might miss this multifocal atrial tachycardia and diagnose them as atrial fibrillation. Actually, in multifocal atrial tachycardia, there are multiple shape of P wave. As example, this P wave is different from this P wave. This one is more broad, and while this one is more narrow and tall, and while this one is biphasic. So different P wave will convey a different wave to the ventricle. So the patient will have sometimes different QRS morphology. So premature atrial contraction is very easy to diagnose. So usually there's is almost similar like multifocal atrial tachycardia, but there's a abnormal P wave that lead to ventricular contraction, which usually a narrow complex. And this proximal ventricular tachycardia, usually there is no P wave before the QRS complex, and usually the QRS complex is bizarre and usually is white. And in this example is the bigeminy, whereas the normal QRS complex succeeded by the followed by a bizarre QRS complex. We call it bigeminy. So in the event of PAC, PVC, or bigeminy, usually the patient will feel their heart become pounding. They have a pounding heartbeat. This is because after the abnormal contraction here, usually this contraction sometimes does not even pump does not cause any cardiac output or minimal cardiac output. So after the period of PVC or PAC, there are period of refractory period where there's a increase in the filling time of the left ventricle. So the subsequent heartbeat, they will cause a forceful and there's increased volume in the cardiac output, and there's this sudden increase in this cardiac output causing the symptom of the pounding heartbeat, not actually the PVC itself. So actually the subsequent beat that causing the feeling of skip heartbeat of the palpitation. So in general practitioner practice or in primary healthcare setting, we always need to rule out Brugada syndrome, because this Brugada syndrome can be presented with palpitation. They can develop ventricular tachycardia, even sinus arrest. So the Brugada syndrome is actually a problem with sodium channel, cardiac sodium channel. Usually it can be provoked by fever, ischemia, and certain drug, and also electrolyte imbalance. The reason why I mentioned that the history of previous history of family with sudden cardiac death, sometimes the patient has a strong family history of sudden cardiac death in patient with having Brugada syndrome. So this Brugada syndrome can lead to ventricular fibrillation and or even polymorphic ventricular tachycardia and even sudden cardiac death. And the treatment usually we implant implantable cardiac defibrillator for patient who has Brugada syndrome. So this is epsilon wave. Sometimes we miss it. So there's actually a positive notch in the after the QRS complex. So this epsilon wave usually occur in the patient who has arrhythmogenic right ventricular dysplasia. Usually this symptom can cause ventricular ectopic beat and also sustained ventricular tachycardia. They are frequently presented with palpitation and even syncope, heart failure, and even with sudden cardiac death. So again, family history of sudden cardiac death is very important. So the mainstay of treatment for patient with arrhythmogenic right ventricular dysplasia is treatment to suppress the arrhythmia. Usually we prescribe the patient with sotalol. Then we prevent thrombus, because the right ventricle usually dyskinesia and there's thrombus tend to develop in the right ventricle. Then we optimize the heart failure medication by doing diuretic, ACE inhibitor. Then we'll try to prevent sudden cardiac death by implanting an implantable cardiac defibrillator. So this example of ventricular tachycardia. So it's very easy to differentiate ventricular tachycardia and supraventricular tachycardia. Usually supraventricular tachycardia is narrow complex, while ventricular tachycardia is a broad complex. So back to a friend of mine. So upon discharge home, he kept having palpitation and shortness of breath. Holter was done at a home hospital and was reported as normal. So because she was diagnosed with initial presenter was chest pain and shortness of breath, so we arranged a CT coronary angiogram and echocardiogram. echogram was normal, and this is the CT coronary angiogram, which show a normal coronary arteries. Then this is the example of Holter report in patient who have palpitation. Usually in the Holter report, we will see the normal beats, how many beats and how many ectopit beats. So then we see the maximum heart rate and the minimum heart rate. Like example in this patient, so the fastest heart rate is 122 beats per minute, and there's some abnormal rhythm here. And while the lowest heart rate occur while the patient sleeping, 42 beats per minute. So usually I will not worry if I see a patient who has 42 beats heart rate of 42 beats per minute while they are sleeping at 2 a.m. in the morning. So this example of ECG Holter monitoring that we pick up a episode of by Germany. So the friend of mine keep complaining of palpitation despite all the investigation was normal. So I advised her to get a smartwatch and monitor her heart rate during episode of palpitation. So she said, she told me that she palpate her own pulse, the pulse is regular, and the heart rate during the episode of palpitation was only about 70 per minute. So I suggest her to seek a psychiatric opinion. So she was diagnosed with as anxiety disorder, and she was started on sertraline and also escitalopram. However, because of the side effect of the medication, she said the symptom actually improved a lot after she was given the psychiatric medication. However, she said she cannot, she's a master student, she cannot concentrate, and she always sleepy while doing her homework and doing his reading, and sometimes she said she cannot even concentrate while doing his operation. So she defaulted her medication, unfortunately. So, but I recently I encountered this this article, tachycardia syndrome, maybe in a patient with previous history of long COVID. So there's a study in this Karolinska University Hospital reported that many patients who had previous COVID, they developed this postural orthostatic tachycardia syndrome, and even palpitation, and usually is resolved after given treatment with beta blocker, ivabradine, compression gradient, and increase in fluid intake. So I'm not sure whether my friend has this tachycardia syndrome. I will see her again in a few weeks later, and I'll probably will do some tail table test to make sure she does not have this tachycardia syndrome post-COVID. So when we talk about psychiatric and cardiology, we cannot run away from this topic of the broken heart syndrome. So actually, there's a real broken heart syndrome in cardiology. Is actually a Takotsubo cardiomyopathy. It was first described in Japan in 1990s. So the patient usually old female lady who presented with typical chest pain. The ECG will show a typical ST segment elevation, usually in the anterior lateral segment, and there's also elevated in cardiac enzyme. So for any cardiologist, when we see a patient with chest pain, ST segment elevation, and raised cardiac enzyme, usually we will bring the patient immediately to the cath lab and do a primary coronary angiogram. And usually the coronary angiogram will show non-obstructive coronary artery disease. Then when we do a ventriculogram, we can see a ballooning of apical ballooning. So actually, this disease is difficult to diagnose, but we should suspect in all patients who has MI with non-obstructive coronary artery disease or MINOCA. So I myself also I encountered a disease in a lady who presented with stroke and also ECG changes and cardiac enzyme, and I published the report in last few years. So this example of the ventriculogram in the patient with Takotsubo cardiomyopathy is actually, the Takotsubo is actually what is that, the sotong trap, yeah, in that used by the Japanese to catch their kurita, you know. So the treatment mainstay for Takotsubo cardiomyopathy usually is supportive. So usually we give ACE inhibitor. If the patient having heart failure symptom, we give diuretic. we give beta blocker. Some people will still give antiplatelet for the patient, and mainly we just give supportive treatment. So I think I reached at the end of my presentation. I pass to Dr. Betty for any question and answer session. Thank you.
Thank you very much. It is quite amazing to see how psychiatric and cardiovascular disease can be linked in so many ways. And I suspect, right, the fact that you presented this Takasubo and how a tragic event can actually bring about physical abnormality in the heart, okay? I think we do not understand enough of, let's say, the hormonal and the system that is going on in us in a cellular level and also in receptors and chemical level to explain this whole situation. But obviously it is very interesting to see, for everyone to see that the symptoms are very, very similar in both cases, and there is always an overlap in both cardiac and psychiatric illnesses. Now where is Prof? Hi, Prof. Come on.
Hi. Yeah.
Okay. So is there any questions? Please either raise your hand and you can ask the questions, or I will ask some questions. Okay. Now, do you know why there's an increase in mortality in patients with MI when these patients have emotional or psychiatric illnesses like depression? Is it because they are less likely to take their medication, or is it something deeper than that?
Okay, thank you for the question. Okay, physiologically, there's some publication to explain. I think a good journal in Archive of General Psychiatry many years ago. Probably this is not the exact explanation, but when they have some emotional problem, patients' HPA axis, hypothalamic pituitary axis, is actually becomes abnormal. So partly the ACTH hormone will drive the adrenal gland, releasing excessive amounts of catecholamines and cortisol. So studies have shown that increase in catecholamines can lead to more ischemia. So this can lead to diminished heart rate variability and even can contribute to ventricular arrhythmia. And also increase in catecholamines can cause platelet activations, which can increase in cytokines and interleukins. Again, can contribute to atherosclerosis and eventual hypertension. And cortisol itself can antagonize insulin, contribute to dyslipidemia, type 2 diabetes, obesity, and so on. So all these probably interplay and probably worsen the heart condition, and as a result, increase in mortality. And also there's a behavioral changes when patients have depression. So they tend not to take medication because of their feeling hopeless, helpless, they tend to become non-compliant to your treatment regime. They don't exercise as usual or properly as advised. They don't take care of their health lifestyle properly. They don't follow your dietary requirement and so on. So all these come into play, physiology and also behavioral changes. All this makes the illness become worse and increase in mortality.
Yes, so it is more than just behavioral changes.
Yes.
The way their mindset and okay. So yes, thank you very much for that.
Prof, can I ask a question, Prof?
Okay.
Actually, the friend of mine that I mentioned just now in my presentation, I asked her consent regarding this presentation to include her case in this visual session. So she actually asked me, Prof, because she's cannot tolerating the sertraline and also escitalopram. Is there any other option that is less drowsy or because the medication she cannot concentrate while she taking the medication, Prof?
Actually, there's a lot of other medication, of course, SSRI, both escitalopram and sertraline are SSRI. It can affect what we call they become blunting of emotions. So they don't, because it improve the anxiety, but at the same time they feel dull, So that's the numbing of emotions. So other medications like the newer melatonergic antidepressants like we call vortioxetine or valdoxan. This is also good for anxiety, especially generalized anxiety disorder. Have much less of side effects. You can also try the vortioxetine, but vortioxetine have more of the nausea and vomiting side effects. SNRI like venlafaxine is also very effective for panic disorder and also anxiety disorder or even major depressive disorder. So actually they have a lot of different types of antidepressants, but for those who are sensitive, you probably have to titrate slowly. So you start at a low dose. And I noticed you combine the sertraline and escitalopram, which is not a good idea. So you must use monotherapy if possible, especially if the patient is sensitive. So you probably start at a lower dose. If escitalopram, start with 5 milligram first, wait for about 2 weeks, then only you slowly increase the escitalopram. If she's in KL, you can refer to me, no problem.
Yeah, she's in Malacca, bro.
Okay.
Yes. Okay. Before we go on to the questions again, now you need to scan it with your handphone while watching on a desktop or a laptop. You can't watch it and scan the QR code to get your CPD points with one device. It needs to be on 2 devices. And if you cannot scan for some reason, please message me. I've given you my phone number, your name, your MMC, IC number, and your email, and we will do it manually. And then coming to your friend, Barclays, I see that she does have a lot of ventricular ectopics. Maybe you try treating that. See?
Actually, that's not her halter.
Oh, that is not hers. I see.
Her halter was normal.
I see. Okay. Sorry about that.
No
So
problem.
another thing that is another symptom that is very glaring in some patients with ventricular ectopic is cough. So if a patient comes with palpitation and they say that their heartbeat is like, their heart is like dropping and they cough, I think it is very common to find that they have ventricular ectopics. Because I say this is because sometimes you do Holter and you will never find anything. Okay, so Dr. Kok T. Lee. Okay, I don't know which is the surname, the Kok or the Lee, but Dr. Kok T. Lee says, what is the recommended antidepressant to be used in patients with depression and concomitant heart disease? Prof?
Okay, thank you for the question. I've mentioned earlier that SSRI is a good antidepressant, which is safe, good safety profile. In fact, there's studies to show that SSRI. There's a study called SAD Heart study among a patient with, I think, post-MI using sertraline, and shows to be safe and effective compared, I think, to placebo. So SSRI, selective serotonin reuptake inhibitor, example sertraline or escitalopram, are very effective for those who have major depressive disorder with cardiovascular disease. Even other group like the SNRI, I mentioned venlafaxine, or mirtazapine, which is the NASA group. It's also relatively safe and effective for treating patients with cardiovascular disease. So there's not really a contraindication for patients with cardiovascular disease for most of the antidepressants. So as long as you don't use the older generations like the tricyclic antidepressant, which is a no-no. Tricyclic antidepressant is associated with a lot of arrhythmia. prolong the QTC interval, or the monoamine oxidase inhibitors. These are all the old first generation antidepressants, tricyclic antidepressants like the amitriptyline, imipramine. Some, I think, neurologists still like to use amitriptyline for headache, for pain condition. You already have the SNRI, which is a better option than the amitriptyline. So as long as you don't use amitriptyline, imipramine, the monoamine oxidase inhibitors, the medications are quite safe.
Okay, we have a question from Dr. Kek Chi Yan, asking whether escitalopram versus mirtazapine. Sorry, I'm not used to some of those. Okay, which one would you prefer in major depression?
Okay, okay. Both are equally good for treating the symptoms, but for different types of patient. Mirtazapine will block your histamine receptor, so it causes a lot of sedation. So if your patient have poor sleep, difficulty sleeping, insomnia, then mirtazapine is a good option because the side effects is sedation. So by treating, by giving mirtazapine, you are controlling the symptoms as well, which is insomnia. So if patient presented with insomnia and depression, then mirtazapine is a good choice. But if the patient does not like the sedative effect, because this mirtazapine sedative is quite strong, it's probably 5 times stronger than your cough mixture. So first time you give, patient might sleep the whole day. Yeah? So mirtazapine is a very sedative medication. So as escitalopram is not sedative. So it's for patient who wants to function, who's working, probably escitalopram is a better option because it doesn't cause sedation. But both are equally effective in controlling depressive symptoms. Both are equally good for major depression. Another thing is that mirtazapine increase your appetite. So long term, it might cause weight gain. Yeah, long term might cause weight gain.
How do we tackle this problem of patients' inability to accept the fact that they may or may not, they may have a psychiatric illness like anxiety or panic attack, anxiety disorder, or depression? How do we create more awareness for this? I want to think of a way, because it takes time for me to explain to patients, you know. Yeah,
okay.
go ahead. Go.
So yeah, there's a lot of patients still refuse to come to see psychiatrists, you know. And the stigma associated, because people always thought seeing psychiatrist, you're either crazy, gila, man, you know, cuckoo. But actually the most common psychiatric illness is associated with anxiety and depression. And I think I always try to explain that anxiety and depression is a medical condition, just like hypertension, diabetes. It's associated with abnormalities in your hormones in the brain. I tend to use hormone. It's actually small, monoamines, but if I say monoamines, the patient might not understand. So I said there's probably your you know, there's a disturbance in the hormones in the brain because of the stress, you know. So when you are stressed for a prolonged period of time, certain good hormones are not enough because of stress. Your body use more of these good hormones, so you need the replacement. So the therapy is more to replace the good hormones that your body lost because of associated with stress and all these the issues. So I tend to explain in a medical term, because otherwise they won't you know, able to accept. And again, the stigma is difficult, but it's improving compared to maybe 10, 15 years ago. It's improving. The youngsters are better, you know. Those who are like students, university students, school students, it's like a trend to visit a psychiatrist, you know. But
yes, I think it is now an awareness that it's not so much a trend, but I think the world and our life has become more and more complicated and complex, that the kids are suffering because of it. So they are having more mental health issues and they are accepting it, unlike us. Okay. Like you say, people will say we are weak if we don't just handle it, but they are more. And I think this COVID situation, as much as it has increased the stress level in everyone is now aware that they need to take care of the mental health more than usual. Dr. Yu Fu Chun asks, how safe is it to use antidepressant in patients who are taking cardiovascular medication, as in statin, aspirin, and what do we need to be cautious about in drug interaction?
Okay, like I mentioned earlier, most antidepressants you can use, and there's very minimal drug-drug interaction with cardiovascular medication. So I mentioned SSRI, the SNRI, even the NASA, the mirtazapine, have very low risk of any drug-drug interaction. The SSRI, okay, if you look at it might prolong bleeding time a bit, just like you are taking NSAIDs. But that is if you use very high dose of SSRI. But it won't interfere with your aspirin or your warfarin. So in general, it is safe to combine with other cardiac medications, the SSRI, the SNRI, and the melatonergic antidepressant, which is called valdoxan. Very low drug-drug interaction.
Okay, Dr. Ko Pili asks, does the use of SNRI in patients with hypertension cause any problem with the control of hypertension with the increase of noradrenaline?
Yes, you have to be careful if it's uncontrolled hypertension. The use of SNRI might increase the blood pressure. So you have to make sure that the patient's blood pressure is well controlled, because there is a reason increase in blood pressure because of the noradrenaline. Yes, that's correct.
Oh, that's a good question. So I need to keep in view of that. Okay, Dr. Chai asks, in what situation do we need to combine two types of antidepressant?
Okay, normally we do not combine antidepressants unless you have treatment-resistant depression, where normally after a patient presented with depression, we optimize with one type of antidepressant. So we go to the highest dose, tolerable dose. If the patient is not improving, then you switch. So switching is the first strategy. You switch to other antidepressant. If it's not effective, then you augment. You augment normally with other agent, then you can start combining. But if you encounter this type of patient, it's better to refer to a psychiatrist, because it's already considered a treatment non-response. The moment you need to switch and to combine, it's more difficult case. So it's better to refer to a psychiatrist. But you can combine, but it's only for treatment-resistant depression. Yeah.
And how many people with major depression will have psychotic presentation?
Okay, they can have psychotic presentation, but normally it's towards the end of the spectrum. It's already very bad. They'll start having nihilistic delusions. They feel that their body is rotting. But the depression, the mood is already very low. So they must have a very severe depression, then only they become psychotic. If the depression is mild but they become psychotic, that is not major depression. It's more towards what we call bipolar disorder.
I see.
So for a depressed patient to be psychotic, the depression must be really, really severe to cause psychosis.
Okay. Prof, can I ask one question, Prof?
Yes, can.
Sorry.
No problem.
Actually, sometimes I got a few patients. Sometimes they really think that they have heart problem, you know.
Mhm.
So what they do, sometimes they jump from doctor cardiologist to
Yes,
cardiologist.
yes.
Shopping.
Yeah,
Mm.
they did everything available. They did CT scan. They
Mhm.
offer for coronary angiogram. They do stress test. Then it's always negative, but they keep thinking that they have this heart problem. What should
Mhm.
how we tackle this kind of patient, bro?
Most likely they're having anxiety disorder. It's not just cardiology, it's either cardiology or gastroenterology. They will be scoped up and down, not just once, not just twice,
Yeah.
4 different. So I remember one of the gastroenterologists, he said, you scope once, you repeat the scope, you will not get a different finding, you still get the normal finding, you know. So this is probably more of the I think they refuse to accept they have mental illness. Dr. Betty said people are more willing to accept cancer diagnosis or other neurological severe diagnoses, but they are not able to accept they have emotional problem like depression or anxiety. I think if they have already went to 2 or 3 cardiologists, I think the third cardiologist should at least try to say probably, you know, you should go and visit a psychiatrist. You know, after all the results seems to be normal, and education, psychoeducation. I think it's a good.
Following to that
So,
question, can I ask whether hypochondria in itself, can it be an illness?
yes, yeah, it's another different illness.
It's a different illness, right? But it can bring about anxiety and everything. But
correct.
the
I thought hypochondriasis is another condition where they think they have conditions.
Is it more difficult to treat?
Yes, it's even difficult to treat, especially if they have this strong belief. It becomes like a delusional already. They have that they have a medical illness. Actual fact, they don't have. They be shopping doctors, and so
Yes.
it's even more
Paying
difficult.
for doctors' children's education.
Correct.
Dr. Yu, we have a question for you, Baklish. Do all Brugada patients symptomatic, or are all Brugada patients symptomatic? Any asymptomatic cases with only ECG changes? Yeah, go ahead.
Yeah, actually sometimes the only symptom of Brugada syndrome is sudden cardiac death. So we just pray that the patient has no symptom. But
the first symptom could be your last symptom.
Yeah, last symptom. Yes. So there are some people who has this Brugada ECG, and sometimes it pick up during medical screening, and sometimes patient presented with some other illness. And sometimes this Brugada syndrome, the ECG can be appear during episode of fever. So in this kind of patient who don't have any previous history of family history of sudden cardiac death, never had any episode of syncope, no symptom of ventricular tachycardia or palpitation, sometimes we still investigate. So what we do, we will do some EP study, and there are a few ways to precipitate it more by change the leads of the precordial lead, and can accentuate the ECG changes, and we can send to the electrophysiologist expert, and they can do some EP study to confirm.
I will expand on that, Dr. Yu. I actually had a patient who was a young lady in the 20s. She had 3 episodes of loss of consciousness. So she fainted 3 times in her office. Then she was admitted. So of course, she had long QT syndrome, but her ECG did not get the long QT. Okay, means there were no long QT on the ECG. It has to be, she needed maybe some form of trigger to increase the QT interval. But then she was admitted, and in the ward she fitted, and she was in Tosat. Okay. Then when asking back, she has a cousin who had actually had sudden death. And when I was in university hospital, I was seeing this family who had 4 daughters, and 3 died in the death in the in their sleep. 3 died in their teens. So leaving the parents just 1 daughter. They had long QT. So the first symptoms could be their last, and some may have palpitation or loss of consciousness or fainting attacks. Okay, that are the symptoms. Okay, Dr. Haji Lazwadi, very glamorous this name. How to escalate the antidepressant dose? Now, what are the indicators based on symptoms improvement or just the fact or the sake of for the sake of maximizing the dose? Or I think what Dr. Haji Lazwadi is asking is, how do we actually titrate the dose? And is this based on the symptoms improvement? And do we maximize the dose as we treat patients with anxiety or depression or panic attack, or do we not at all?
Okay.
Prof?
Okay, thank you. Okay, I just give for SSRI, example, escitalopram or sertraline. For anxiety, I'll talk about anxiety first. So for anxiety, you try to start at a lower dose, because if you straight away go to the optimum dose, the initial period, the anxiety might get worse. You go straight away the optimal dose. So if you say, for example, use escitalopram, which is one of the most common SSRI, so you start with 5 milligram first. 5 milligram, wait for 1 or 2 weeks. If patient tolerate it well, then you increase to 10 milligram. And if the anxiety is very, very bad, then probably can combine with with benzodiazepines like alprazolam or lorazepam to control the anxiety symptoms. So you go at the lower dose first, then after 1 or 2 weeks, you go to the higher optimum dose. So like if you start with 5 milligram escitalopram, then after 1 or 2 weeks, you go to 10 milligram and see again, wait for another 2-3 weeks and see the response. If no response, then probably you can go another 5 milligram upwards. Okay. So similarly, if you use sertraline, you start with 25 first, then go to 50, slowly go up. So that's for anxiety. For depression, you can go straight to 10 milligram. If that patient does not have any symptoms of anxiety, you can straight away go to the optimum dose of, for example, is escitalopram, you can start with 10 milligram. But if you think patient is sensitive to side effects, it's no harm starting at a lower dose first. The first week, start at a lower dose. Then patients tolerating the medication, then you go towards the optimal dose. You don't have to go to maximum dose. So optimal dose, for example, for escitalopram is 10 milligram. Optimal dose for sertraline is 50 to 100 milligram. For SNRI like Effexor or venlafaxine is 75 to 150 milligrams. So depending on which medication you want to use.
I think, okay, Polyclinic Tay asked, which antidepressant or anti-anxiety drug is preferable for irritable bowel disease? Do you use it?
Yeah, it's again, either the SSRI or the SNRI. You can control well
very
the
much
anxiety
related to anxiety, right?
Yes, correct.
So again,
so IBS is
I think the
good.
message is that the patients actually, the symptoms is real. They're not imagining it. It is actually
no.
Yeah, it's just even though people say it's upstairs problem, but it is a real symptom. Okay, and
correct.
And it is a treatable thing. I think we need to get this message across that anxiety and panic attack and depression is very common in our practice, okay? Seen by many doctors, either the GPs, the cardiologists, the gastroenterologists, okay, before eventually going to see the psychiatrist.
Correct.
It is a very important aspect of life to be treated, because you want to have that certain clear mind, peaceful, not sad, not anxious, and then you will be able to achieve so much more in life. So Dr. Yu asked, Brugada if asymptomatic, any need for specific intervention? My classmate is living in Italy, no symptoms but confirmed Brugada. The cardiologist is not offering her any specific treatment. Barclays.
Usually in Brugada, the only effective treatment is to prevent sudden cardiac death. Usually we just offer the patient with implantable cardiac defibrillator. But cost probably an issue. In Malaysia, if I'm not mistaken, it costs about 60,000 to 80,000 per implantable cardiac defibrillator. And every 8 to 10 years, probably you need to change a new device, But of course, there are a few criteria that we need to consider whether there are three main ECG types of Brugada. Usually the higher risk is the type 1. Then they need to ask whether there's any previous history of sudden cardiac death or any symptom, any history of syncopal attack or palpitation. And sometimes the cardiologist will offer some provocative tests. Usually we give adrenaline, but the adrenaline is not widely available in Malaysia. Probably only in IJN in Malaysia is available. So I'm not really sure what happened to your friend, but usually if I see a patient with Brugada, I will offer them with an ICD.
Yeah, I think it is only right to explain the need for an implantable defibrillator, because like we said before, the first symptoms could be the last, and usually we see it in young people. I'm sure your friend is a young lady. Is there any role of beta blocker in Brugada? Beta blocker is useful in long QT in reducing the risk, but I'm not sure about Brugada. I don't have any experience with Brugada.
I don't think there's any role of actually beta blocker.
So really, your friend, if really is confirmed Brugada, I would suggest that she put in an AICD. It is very, very life-saving in that sense. Is there any more question? If not, we will end this session. It's amazing. The attendance was very good. And even after that, there's still 82 people. Sometimes when I organize a webinar, by the time the QR code has been given, everybody would have left. Because so 10th of 10th is the World Mental Health Day, which is tomorrow. Please, okay, as doctors, I think we play a role in not just diagnosing patients with mental health illness, but creating awareness among everyone, our family, the patients, relative, and the need for treatment. Okay, so I think that I hope with this Mental Health Day, we'll be able to create more awareness, and patients can, and we all can live a happier and healthier life. Anything you want to add, Prof. Bucklish?
I like your statement just now. You should live without fear and sadness just now.
Yes, fear. You know, because why I say that is because one of my patients, okay, he has had, okay, and a lot of it was also his own fault. He has had anxiety disorder since he was 16. Every time he see a cup, if there's any chip or anything, he'll get panic attack. And then he has seen so many people, and yet he comes to a cardiologist again. Okay, I'm not the first cardiologist. And he said to me, Dr. Betty, do you know how it feels to wake up every day feeling scared? And that really struck me, you know. That statement, like, okay, so after that statement, right, I keep on telling people, okay, there is actually no need to feel scared if you get treatment. Yeah, so I really think that it is very important. Tomorrow is World Mental Health Day, that we instill in everyone that, okay, yes, life is difficult, but a lot of the unhappiness, okay, can be treated, and we can cope so much better with whatever life throws us, right, Prof?
Yeah, can I borrow your
Oh, please.
quotation next time?
Yes,
Very
sharing is caring. Yes,
Very
please.
nice, very nice. Yeah.
Yes,
Yeah.
very informative. Thank you. Put in very simple terms, because it's very important, because I also shared it on my Facebook. So a lot of public will, you know, realize that how easy and important this is. Live life without fear and sadness.
Yeah.
Prof, so
Thank you very much.
yes, we can go on to see Prof to live life without fear and sadness. Thank you so much,
Thank you.
Prof. Thank you, Baklish, and all the
Thank
best,
you, Dr. Betty,
Baklish,
Dr.
back
Prof.
to Kuantan end of this year.
Yes.
I hope you do well.
Thank you, Dr. Betty.
And I'm
Be in
so
touch.
happy that you didn't take up psychiatry. Sorry, Prof. Sorry. But I'm so happy you didn't take up psychiatry. Okay, see you guys.
All right.
Okay, bye-bye.
Thank you. Bye-bye.
Bye-bye. Have a nice weekend, everybody.
Yeah.
Bye-bye.
Okay, thanks everyone in Torrent. Of course, this is a sponsored talk by Torrent. We need to mention this. Okay, Torrent, thank you so much. Bye, everyone.
Bye-bye.
Thank you so much, Dr. Betty.
I think it was very good, yeah.
That was very interesting.
Very interesting, yeah. I think Prof and Baklish did a great job. And I think it is easy to, it's something that the public can also accept. So this type of talk is very interesting for everyone.
Okay, Dr. Betty. Nice to
Hey,
meet
bye.
you.
Have a
Take care,
good
Dr.
weekend,
Betty.
Baklish.
You too. Bye-bye. Bye, Vanessa and
Okay,
the Torrent team. Bye-bye.
Dr. Yu, yes, we have a recording. I will download it and I will upload it on YouTube, Beating Hearts channel. Yeah. Anyone? Oh, everybody's. Okay. Anything, Torrent?
No, Dr. Betty, I think we can end this session today. Thank you so much.
I think it was very nice. Yeah.
Yeah.
I'm very happy with it.
Happy with it too.
The next time if you
Okay.
because it's published to the public, so I didn't mention Torrent because I don't know what is actually the pharma code. Yeah, I don't want people, you know, sometimes people are going to complain to you, complain about you, so I didn't want to do that. So
Okay, no problem.
yeah, if it's doctors only, we have no problem.
That is very fine with us, Dr. Betty. No,
It's
no worry
fine,
about
yeah?
it. Yeah.
Okay. Yeah,
We're really grateful actually for the first time, Dr. Betty, you're allowing us to actually get connected to your Beating Hearts platform. Yeah, today's topic's very interesting and very insightful. I feel many of us should be very inspired with the sharing. And honestly, I keep telling Vanessa and Katie that you are amazing. Really. Yeah, you're amazing. Yeah, it's very lively and the kind of way how you actually helping us.
I see. Okay, thank you so much. Yes, thank you very much. I just while I was doing this, I didn't think I was amazing, but I thought that, oh, I'm probably can make a good TV host.
Yes, you are.
We did the same too, Doctor.
I was texting yeah, two of my product managers saying, well, you already have that kind of quality. Normally the webinars, what we did is usually the doctor will post their questions, then we just read through the questions. But with you, I think it makes it more lively.
Yeah, I'm quite. I think I'm a good moderate, good host, like in that sense. And it's I found the niche because I am too lazy to do talks by myself. So I'm too lazy to do slides. And then I enjoy this hosting very much, and enjoy it really much because I meet people and I'm able to bring fun to the talk. So I really enjoy it also. Thank you so much. I know it's a bit thick-skinned to agree with you, but I do agree with you in the sense that I do. You so many people still around. Oh, thanks. Okay. I thought that everybody has left except the Torrent people. So sorry. We are now what you call it, doing a post-mortem.
Yeah.
Post-mortem.
It's a good one.
We are 40 over people still around. Okay. So,
I'll give a thumbs up. Thank you so
thank
much,
you.
Dr.
Okay.
Betty.
So I'll speak to Vanessa. Maybe we can
Sure.
speak about further collaboration. Yeah.
Yes, that's good. Good idea.
Yeah. So maybe we can, I'm thinking that this Prof is a very, quite, he's a good speaker, and he's can answer, the Q&A is important. So Prof is good with Q&A also. So we can do more than this. Yeah.
Sure.
Okay, I'll say bye to you guys.
Still, have a good evening.
Yeah, have a good weekend, yeah? Bye-bye.
You too.
Yeah, thank you,
Bye,
Dr. Betty.
everyone.
Thank you, everyone. Bye-bye.
Guys,
Thank you, Dr. Betty. Bye.
there's still 40 people here. Okay, bye. Okay, love you guys. Bye.